and I welcome our esteemed panelists and hope to learn from all of you. Like Dr. Leena said, it is actually an obstetrician's nightmare to be caught up in that situation. So we have a very normal case that we see quite a few times. This is a 27-year-old primary gravida, so to say a low risk. All her routine antenatal investigations have been within the normal range. She comes to you at 38 weeks for a regular checkup. She was just having mild backache. Pulse BP is all settled. Abdominal examination is a corresponding size pregnancy. You feel it's probably an irritable uterus, or maybe she has some mild contractions, but not very good established contractions. Cephalic presentation, fetal heart is absolutely fine and regular. On a per-vaginal examination, it's a bachelor source, uneffaced, head is at -3, and it's an average gynecoid pelvis. Now, the problem is that she stays 15 kilometers away. You discuss the logistics with her. She's not very comfortable going back and is not able to decide whether to go back or come back again in active labor. But eventually, both of you mutually decide that she gets admitted. Now, once she's admitted, the clock starts ticking. You observe her. She's still irritable, getting very mild contractions only. And by about 18 to 20 hours, she does not progress. The findings remain the same. It is now you start the process of induction for her. She starts getting contractions. You are quite relieved. But lo and behold, you go on the next round, and suddenly on auscultation, there is no fetal heart that is seen in the first stage of labor. You immediately call for help. Auscultation is attempted. CTG is attempted by 2 people. You are still not able to find any fetal heart sound. Too much of panic and stress, but you eventually calm down and you declare to the relatives that there has been an intrauterine fetal demise. My first question to you, Dr. Archana, was there anything wrong when we did this? So if there is any other panelist who would want to attempt on it?
I can answer the question. That anything wrong, we cannot say exactly that anything wrong, but we have to be very clear in our mind when we induce a low-risk woman, primary gravida, 27 years old. So first the cause of induction, and then you have not written, you have not told about the
confirmation. To the induction part a little later.
Yeah.
But here a very pertinent question comes is, do we actually declare that there has been an intra-demise solely on the basis of auscultation or a CTG? So
No. Ultrasound is important actually, and it's to be a real-time ultrasound.
Yes.
One cannot depend on the CTG because patients might have passive movements, and even if you auscultate and do not find the fetal heart, many a times you'll find live babies. Yes. So it's always a real time.
Yeah, in fact, there was a large series that was done, and it was seen that in as many as 22% of the cases where on auscultation you were not able to hear the fetal heart, there was a definite cardiac activity. So auscultation and CTG are not to be relied upon to confirm a suspected IUFT. A real-time sonography is the gold standard. Now, the problem comes that ideally, yes, we say that real-time sonography should be available at all times. But this may not be the case for all centers. When you're talking about pan-India, not everybody would have the facility for a sonography. And there, if you do not have the facility and you cannot ask for somebody to come and do, or you could not send the patient also, there it is acceptable that yes, you have tried to localize it with auscultation and CTG, but not as a routine. Wherever there is an option that is available, a real-time sonography should be there. And in case the patient wants, please go ahead for a second opinion from an other radiologist. Do not be in a hurry to start the management for her. This is extremely important. We need to understand that it is a big news for the parents and for the family to allow them to sink in. So if they are not comfortable and they take time to accept or they put in a request, please go ahead and heed to that request that if they want, please go ahead for a second opinion. Like you rightly said, mothers also have to be told about the possibility of a passive fetal movement. The bowel movements might be mistaken and they might ask you to do a repeat scan. Auscultation can give a false reassurance because the maternal pelvic blood flow can be picked up.
Yeah, one more thing is, if supposing you have detected IUD on ultrasound and the patient continues to say that I'm feeling passive fetal movements, it's a good idea to repeat another ultrasound and convince the patient that it is an IUFT.
Yes. Another objective assessment that you get with a real-time ultrasound is you get a direct visualization of the fetus. So maybe you will get some additional information that led on to this situation. Here, when we have started talking about a live fetus and a good FHR, you might be in certain cases be able to pick up a placental abruption. So the sensitivity is very low, but that could be picked up. In some situations where the cardiac activity has disappeared, that again will help you in documenting and getting to the cause. So you might have, if it has been more than 24 hours, the other features of IUFT, and those also can be documented. So that is also another advantage that you get when you talk about the scanning, why it is important. Coming to you, Sangeeta ma'am, this is a very, very stressful situation. Now, before you go on to discuss that how you will break the news and how you will go about explaining to the relatives, it is extremely important that first we learn how to take care of our own self. So since you are the senior most, we would like your guidance on this, how to handle yourself and how to break the news.
Thank you, Dr. Nidhi. I know that this is a very devastating situation, and doctors as well as patients both are in stress. And the effect of the condition is on the doctor also and on the patient also. So first of all, like we prepare for any exam, we have to prepare ourselves for breaking the news. Now, the preparation for ourselves is that we have to collect our thoughts and emotions. We have to be very calm, composed. Then we have to gather the relevant information in detail about the patient, and if there is any confusion, we can discuss with our colleagues also that this has happened in this case. What do you suggest? What can be the cause? So we have to be prepared for all the questions which a patient relative can ask from you, and we have to have a detailed checking up with the case sheet. Then you have to have a supporting staff with you before you present yourself to the relatives. And after knowing the details, having a supporting staff with you, keeping yourself calm and composed, having an empathetic attitude, you should choose a place which is safe, secured, and comfortable, and call the relatives. Sometimes it may be that no relative is there and patient is only there, then also you have to break the news to the patient. And if relatives are there, then you have to call the relatives. And it's better that you call from both the sides of the patient, because she's a young primary gravida, that maternal as well, mother ki taraf se bhi or in-laws ki taraf se, if it is possible, you can call. And you have to break the news in fragments. Means dheere dheere you have to say that you have to be empathetic, that I am really sorry to say there is a sad news, that but it has to be very clear. You should not use any medical jugglery ke ye hua wo hua plana. It has to be clear but empathetic ki the baby is no more, or we are not able to find the fetal heart both by ultrasound or this thing in the baby. So then you have to give some time so that they may digest the news. They may know that because it is quite heartbreaking for them and quite spontaneous, sudden for them. So give them some time. Then you may say that this has happened, but limit yourself. Let them ask the questions and be prepared and answer the questions in as simple way as possible. And be present there. If they further ask any question, don't leave them just telling ki this has happened. Just be there, be sympathetic, empathetic to them rather. And I think once the news, you can ask about the next step, that what is the progress of labor, how to continue the labor, what is the further treatment and management of the patient. So in nutshell, we have to be very empathetic, very direct, gentle, and compassionate and very patient and be present. Patient and be present. These two are the things that don't leave the patient's relatives. So I think this in nutshell is how to prepare yourself for the...
May I add something? Madhu?
Yes,
Definitely.
Yeah. What I feel is it's very important not to say that I made a mistake. I had my, one of my associates, she just broke down, into tears. And we had to literally tell her to sort of gather herself. Otherwise, she keeps saying, oh, why did I give her a trial? Why did I give her a trial? Why didn't I do, it's like admitting that you made a mistake. So the message is here.
That's the
not
first,
to say
how
that.
do we take care of ourselves
Yes.
first before
Yes.
we go on to sit
Yeah.
down with the patient?
Yes.
So take a moment or two to gather our thoughts, gather what all we are going to say, and then talk to.
So preparing for breaking the news is very important, and assure them that everything has been done to assure the status of the baby. Means during labor or whatever the procedure, we have to make them sure that yes, we have done it. Like a sick patient, हम कहते हैं ना उसको बचाने के लिए हमने सब कुछ किया, पर फिर भी हम नहीं बचा पाए. In this case, you have to say कि बेबी की कंडीशन को assess करने के लिए जो भी प्रोसीजर था हम सब वो फॉलो कर रहे थे. But it is really sad that this has happened. So you have to assure them.
Yes, but
Pratibha,
actually,
you want to say something, Pratibha?
No, only that we have to defend all our actions and not say that we have gone wrong.
Yeah.
And as Dr. Sangeeta said, we have to ensure them that all actions have been taken, all monitoring was done. And sometimes these things do happen. We can tell them some percentages. As per the books, it is about 20% unexplained IUFD. So we have to explain them all that, convince them. And of course, not talk too much of medicine. In very simple language, as a layman, we have to talk to them.
yeah. But actually, this whole process of breaking the news is easier said than done. So when we talk about empathy, when we talk about all those words, we ourselves need to get trained as to how to talk and what to talk, what words to use, our body language. And would be a good thing that if we take up these small skill enhancement things for breaking the news.
I will just like to add that if we can call one or two of our colleagues, say, let us say that we call the anesthetist who is on duty, we call the pediatrician, and in a group of 3 or 4, together we break the news, all talking on the same platform.
That's extremely
So
important.
that is where we defend ourselves, and they also get an impact that yes, there was a group of doctors. But I have had a bad experience, which I think there was anesthetist with me, there were other doctors with me, my associate was with me, the SR was with me, everybody was with me. Even then they behaved very violent, and it's last 6 years that I'm facing the music following that case. It is going on in 3 courts. And I'm all the time running and spending money, and so much of mental trauma I'm going through. So it is very, very difficult to handle a sudden intrauterine fetal death when the patient is in the hospital. That is very dangerous.
That's an extremely unfortunate.
How much ever we may convince them, they feel that we have been negligent and we brought the patient fine, and you told us that baby is fine, she's going to deliver by this time, and now you're telling me that baby is gone. So they don't accept it,
Yeah.
That is the
Here comes the
whole
role of consent, Dr. Nidhi, that we will discuss, I think, maybe later. That free counseling,
another
as
good
Madam Jain always
practice.
says.
Yeah, another good practice that can come in one of these situations. A good practice that can come is that when you are sitting down and explaining to her and talking to her, you could have the option of a video recording the session. You know this is a potential problem. You know that this will be a potential litigation. So you could, with the patient's permission, record your discussion wherein you have spoken about those things.
That facility should be there in every counseling room of every hospital.
Or we can do it from our phones. All of us have smartphones, and that can also be, we can ask one of our team members to be doing that. Okay, getting on to you, ma'am, Dr. Pratibha, ma'am. Now, unfortunately, this has happened. So what is the minimum and mandatory evaluation for the stillborn that is required? I will split this question into 2 parts. So we'll be talking about the minimum evaluation for the fetus, and then we'll come on to the next question for the placenta.
Now, first of all, I would like to go through all the records once again, going up to reverse whether she had an IUGR,
No.
how was the placenta on ultrasound, what was the birth weight.
We're just wanting to first understand the evaluation. You have the stillborn fetus in front of you.
Achha, you want only the fetus, not
Yes.
the maternal evaluation.
No, that's a separate thing where we're talking about the records.
Now, first
Only
of all,
the
we
evaluation
will
of the
look
fetus.
at the fetus, look for any abnormalities, look at the skin color. Of course, it is a fresh stillbirth, so we know the skin will be good. Assess the weight of the baby and look for any features of abnormality like Down syndrome or other genetic defects which may have been missed and could have been the reason for a fresh stillbirth. So that is how I think the examination of baby should be. And of course, we should look at the palmar creases. We should look at the eyes angle and the nasal bridge and the other features of Down syndrome.
Dr. Jharna, would you want to add anything?
Well, actually, the mandatory investigations involving the fetus, the umbilical cord, the membranes, and the placenta. These are the ones which have to be actually
Yes.
taken.
When we look at the fetus, what all parameters are we wanting to examine in detail?
So the examination should be done by either a neonatologist or a perinatal pathologist. The weight of the baby, the length of the baby, and
A
the
lot of situations, sorry for interrupting, we may not have a perinatal
Yeah,
pathologist.
I think it has to be the obstetrician and the pediatrician.
and
Yeah.
the neonatologist.
So
Yeah.
the person who has attended the delivery is qualified to be examining this fetus,
And the pediatrician and neonatologist can be called in.
and the pediatrician could support your findings.
Yeah.
So it could go as a documentation, it could go as a common documentation from both the obstetrician and the attending pediatrician. Ideally, it should go as a documentation from both.
I think, Dr. Nidhi, I would like to add something. Basically, when we are evaluating the fetus, we have to keep, 3-4 aims in our mind, that we are evaluating the gestational age. We just want to know whether there is a fresh stillbirth or it was an intrauterine death. So we will look for the features of maceration, and then we can go in for a fetal autopsy. We can go for the X-ray examination of the fetus. And our aim is basically to know what was the cause of, death, and whether it occurred during labor, mostly because of asphyxia or traumatic injury, or it was a antepartum medical disorder which has led to the fetal death.
Thank you, ma'am. So this is your opportunity to safeguard yourself. There has been an unfortunate event. You cannot go back and rewind it. But what will really help you in the court of law will be the kind of documentation that you have done at this point. Because here you are, like you rightly said, we are like wanting to pinpoint what was the probable cause. So a detailed examination of the stillborn fetus is absolutely mandatory, and it is a head-to-toe examination written specifically for each of the organs. You start from the external appearance, you start from the appearance of the... anybody was wanting to say something?
Yeah, what I was talking is the obstetrician actually, just can ideally put in the weight of the baby, the external examination, but all the detailed examination is expected from a pediatrician.
Yeah, that's why it's supposed to go as a joint documentation. So you start a head-to-toe examination. You will take the weight of the baby. You will take the length of the baby. You will measure the head circumference. If it is a preterm, you will measure the foot length. You will talk in detail about the description of the facial features, eyes, ears, nose, mouth, cranium. You'll try and open the mouth and see if it was a large tongue to rule out the Beckwith-Feldman syndrome. You will try and look for neck and the back for any other abnormalities, any abnormal pigmentations. You look for skin changes. You will look for the cord insertion, the abdominal wall. Does it have edema? Does it have any other organs coming out? It is extremely important here to look also for the gender. You have to clearly specify in your notes whether it was a male or a female. Now, there may be a problem in case it is a severely macerated fetus. You are not able to give the gender. Then The baby can be registered when you are filling up the certificate as indeterminate sex awaiting further tests, or you can quickly order a rapid karyotyping using a QF-PCR or a FISH. You can get the report within 24 hours and then go back and complete your records. But you have to clearly talk about the sex, and if you're not able to clearly make out, please don't make a guess and say male or female. Say that it is indeterminate and we need further investigations. We need to photograph the fetus here from different angles. So you need to photograph the head, face, whole body, hands, feet. Take detailed photographs of the baby from the anterior, posterior, and lateral directions and record any abnormalities. Now, Ila ma'am, when we talk about photographing the fetus, do you think we have any issues with that?
I think it is important to see the baby and unclothe the baby and examine completely, and then take the photograph from all the angles. You have to see the you have to take the permission of the relatives also. Take the, not exactly if they don't allow to take the photograph or something like that, you should understand their feelings also. But usually they allow if you really counsel them, because this photograph will help us to understand for the future pregnancy. And then you have to put these photographs in the case sheet as well as, or if the patient relatives want to have this photograph with them, even then you can give it to them. And for us, for evaluation of the fetus, you have to see the any dysmorphic feature or something, or you have to take the extremities completely. You take the photograph of front, lateral profile, extremities, palms, and then you have to see the any dysmorphic feature and concentrate on that particular aspect and take the close-up pictures of these things, so that you have the record of all the things. Before that, you have to also think of doing or radiography of the whole skeletal system also. Yeah. And see, because there is some foot length is a very, very important thing, because less than 23 weeks.
Yeah, that length. We really want to impress upon, and all of us should remember when we are talking about photographs that no photographs of the fetus are taken without a written consent. It is an absolute no, capital bold underline, you cannot take. So whenever you are talking about the evaluation and whenever you are talking about photograph, you have to obtain a consent to photograph the baby, and be aware that sometimes they may not allow you, but that's okay. Dr. Renu ma'am, what is the minimum and mandatory evaluation for the placenta? Now, this placenta is actually a storehouse of information. You cannot discard it. But before you send it to histopathology for the pathologist to examine, what all is mandatory that should go on in your notes?
Thank you, Dr. Nidhi, for having me here. I think gross examination of the placenta, if we do it carefully, both the fetal surface, the maternal surface, the umbilical cord, and the membranes. If we examine all these structures very carefully, grossly also, it can give us a very valuable information regarding the cause of fetal death. And it has been shown that if we only focus on the clinical information and examination of the placenta, about 85% of the cases we will come to know about the probable cause of death. So the examination of placenta is so important. So as we know that placenta has a maternal surface, it has a fetal surface, it has an umbilical cord and the fetal membranes. So we have to examine all these things very carefully. I would just like to give few examples. For example, we know that the placenta is about 500 grams, which is 1/6 of the fetal birth. We take it average. A large placenta or a placenta which is weighing more than 500 grams may be seen in diabetes mellitus or fetal hydrops or in certain fetal infections. Similarly, a very papery thin placenta, which is less than 2.5 centimeter, will give us an indication that this may be a cause of fetal growth restriction. Then we look at the maternal surface and we can look for the clots, which may be very relevant in the presence of placental abruption. And on the fetal membrane, we can see the thick ring of fetal surface membranes like in circumvallate placenta. Then if we examine the membranes and we see that there are vessels going through the membranes, then we may be dealing with the case of vasa previa, where the fetal hemorrhage can take place. The umbilical cord as such, a very short umbilical cord or a very long umbilical cord may be associated with complications. The normal length of umbilical cord is 40 to 70 centimeter. A short cord may be associated with cord rupture, hemorrhage of the cord, prolonged labor, and a long cord can give rise to cord entanglement. Then there may be presence of knots, which are false knots or a true knots. So all these things have to be noted and documented. Then if we look at the vessels in the umbilical cord, supposing there is a single artery, then it may be associated with fetal about 50% of the cases if there is a single umbilical artery and a vein. Normally there are two arteries and a vein, but if it is a single umbilical artery, it may be associated with many fetal anomalies like cardiovascular, genitourinary. And then we look at the membranes. If the membranes are dull, opaque, maybe because of infection, intrauterine infection, or they are foul smelling, it is a foul smelling placenta, then we have to think of intrauterine bacterial infections like streptococci or a clostridial infection. So if we even look at the gross examination of the placenta, it can give us a lot of information. Then the placenta tissue can be sent for histological examination and for the cytogenetical analysis, which will also tell us the cause of fetal death.
And the membranes for culture also.
Yes.
Okay. So very beautifully covered. Thank you, ma'am. The only thing that I would want to add a little further here when we talk about the placental description is a concept that is very much upcoming, is to talk about the cord coiling. Now, it has been seen in a lot of situations that the coiling of the cord, whether it is a hypercoiling or a hypocoiling, both of these are associated with an increased risk of FGR as well as a sudden IUFD. So when we talk about an unexplained IUFD, a lot of time it is that these placental things have not been evaluated, like you correctly said. So we need to document, because we don't know, maybe if this turns out, this could really come out as a good point to work in your favor. If you have documented these things very clearly, then it goes on to prove beyond doubt that yes, it was not an obstetrician's goof up. So
I would like to add one thing, that for if the stillbirth is associated with multifetal gestation, then the study of the placental vasculature at gross level can also tell us regarding the cause of fetal death in such cases. So we can do that also grossly and see if there is sharing of vasculature in the placenta.
So that's both for a multifetal as well as for a single gestation. Specifically, we describe how the cord coils. So if the coiling is uniform, then you need to count the number of 360-degree coils over a 5 centimeter length of the cord. If the coiling is non-uniform, it is not occurring repeatedly at regular intervals, then you count all the 360-degree coils in the cord and divide by the entire cord length. And this is what is called the umbilical coiling index, or the UCI, and you need to document it. True or false knots you have spoken about, cord edema, hemorrhage, laceration, avulsions, their insertions. Cut the cord every 5 centimeters and record the thickest and the thinnest diameter and the number of arteries and veins you will get in the cross section. Cut the cord leaving only 1 centimeter of the stump attached to the placenta, and then you need to weigh the placenta after it is drained of blood. You measure the longest and the shortest placental dimensions and make note of any extra lobes or unusual shapes. So this, a lot of it will be done by the pathologist, but the problem is that by the time you send the placenta to the pathologist in formalin, the coiling would have been lost. So you would have lost that opportunity to document if it was related to a coiling incident, and that was the reason why I wanted to bring about this point.
Dr. Nidhi, I just want to, discuss one case. There was a delivery and there was a case of sudden fetal death.
Can I request you
And when we examined the placenta,
can
we
we just finish
noticed that
off your question?
the maternal surface of the placenta was very pale.
And there are some people who are also raising some queries. My request to them also from the audiences that we will take up the questions once we run through the panel. Okay, so autopsy we know is ideal, but here it is important that do not force the parents to choose autopsy or to go through. It should be a gentle suggestion. Here again, you need to draw a balance, that you need to tell them that we will get additional information. But again, you cannot impose and you cannot force yourselves on them. So if the parents are willing for autopsy, yes, that is an ideal situation. But if they are not willing for autopsy, Dr. Jharna, what will be a limited autopsy then?
Okay, if they're not willing for autopsy, then a limited autopsy can be done, and but they need to be told that it will not reveal too much of an information or much of information, because the autopsy is the single thing which discloses a lot of information why the stillbirth has occurred. Limited autopsy, even if we give them an option for limited autopsy, basically we have to take the photographs, we have to take all the examination of the placenta, histology of the placenta, and we have to do skeletal X-rays also. So these are the things that we take. Sometimes we might take needle biopsies, but of course they do not give too much of information. We might take biopsies from the skin, from the cartilage, from the skin doesn't actually, if you have to take it from the skin, it has to be from a deeper muscle layer.
Yeah.
And if you have to take it from the cartilage, it is hard to process and it's difficult to get too much of information.
A patellar cartilage is a good area to take.
It's a good area, but then it is very hard to process, and that also may not yield too much of an information. And skin, they say, also does not yield too much of information. But if you are taking skin, you have to take the thigh skin and a deep muscle. And sometimes it might be that the parents want that we want only the heart to be seen. Then you'll have to tell them, if you have to see the heart, we have to see the thymus also, we have to see other organs also. So these are things which are called limited autopsy, but they do not give too much of an information as to why the stillbirth has occurred, and this has to be told to the parents.
Yes. And obviously, without any doubt, whether they are willing for an autopsy or not, placenta is not to be discarded after the gross examination. It has to be sent for a pathological examination. If you have a perinatal pathologist, fine. Otherwise, a general pathologist. And this has to be backed up by the relevant imaging. Someone was saying initially only, we need to do the X-rays. So an infantogram is a must. We need to do that. And the infantogram needs to be done before rigor mortis sets in. So you cannot do an X-ray the next day morning, because by that time there would have been contractures which would have developed and you would not get an accurate idea as to the shortening of the long bones. So infantograms or all X-rays need to be done before rigor mortis sets in. Investigations for infections to be sent. And if we are sending for cytogenetic analysis, then again here it is mandatory that we need to take a written consent from the parents.
But a karyotype can be sent, the membranes can be sent for karyotype.
Yes, that's a cytogenic analysis, ma'am.
Yeah.
And for that, we need to have a consent. It can be sent, yes. But again, it will depend upon if it is a macerated fetus. We may not always be able to grow live tissue out of it. So it will also have its limitations. Coming to you, Ila ma'am, what safeguards?
I just want to come in actually.
Yeah.
Regarding these autopsy and regarding these genetic studies, it is always better to ask for a microarray, because we will not get live tissue, and microarray just takes the DNA. But if you're asking for a karyotype, you need live tissue. So if it is a fresh stillbirth, then perhaps the placenta will be the only thing, but placenta has a lot of mosaicism. So we need to understand that when you're saying, when we are taking placenta or anything and sending it for a microarray, we need to send it in saline and with a little bit of antibiotics over that, or sometimes they have culture media also. So that we need to thaw and then send the specimen. Because nowadays, autopsy, they don't agree. But at least for a cytogenetic studies, the parents are agreeing.
Yes.
And then we can come to some, if there are deletions, if there are micro deletions, or if there are some problem, then we can come to know about it. But again, one more thing, if there is like balanced translocation, then the microarray will also not suggest. So then you have to need a karyotype. So all this knowledge should be there with us before we proceed for cytogenetic studies.
Yes. The only disadvantage comes is that karyotyping will come at a higher cost. So that also has to be kept in mind. But as compared to, microarray will come at a higher cost as compared to karyotyping. So that again is a point of discussion with the parents ultimately. Trading off the information that you will get vis-a-vis the cost that is.
Yeah, actually, this is a very, very important process which you have to deal with everything, because this will save you from the medical legal action in any case. So first of all, starting from the beginning, you have to record everything, what a maternal condition and all the detailed of the patient's information should be documented very properly. There should not be anything missing, which can conclude that there was a cause of stillbirth was lying there, and you have to document in chronological orders all the things, and whatever you have not documented, I think it is better that you sort of see all the things and again enter those things which you have forgotten or you have not seen. Whatever anesthesia you were taking, that should be photographed and digitally kept with you, as well as in the case sheet. And then you have to point out at what level the fetal heart was there and when it was not there. So you have to document each and everything in the case sheet, and you should be knowing that at what time the sudden fetal demise happened and what is the time interval between the demise and delivery. And then you have to, whenever you are going to talk to patients, you have to, relatives, you have to be knowing very keenly in yourself that what is the, can be the cause of IUD in such cases. And you should be very, very smart in dealing with these cases. And first of all, you should be very comfortable, as ma'am already said, that you should be dealing with yourself first. And secondly, then after noting down all the documents in the case sheet, all the events, whatever had happened, what are the reports, and everything should be noted down in the case sheets. You should also be, after finishing out those things, when you see that it is written properly and everything is done, then of course you have to take the consent of relatives whenever you are going to transfer them the baby, and whether how are they going to sort of cremate the baby. That discussion has to be done with the relatives, and you have to note that document has to be attached in the case sheet. And there is a the team is there in each hospital which is dealing with such kind of events, and they should be involved in it. And there is a form also which is there in the hospital, which has to be filled and which has also to be kept in the case sheet itself, which shows that what happened to the baby and at what time the baby died and death, and all the sex of the baby, as already told, that if it is you do not know the sex of the baby, then you can write down the indeterminate sex.
I think it is very important to, do a recording of the fetal heart. There should have been an admission test, between, admission NST, which tells us that when the patient presented to us, everything fetal heart wise was normal. She was having no contractions or whatever. If she was having any contractions, the TOCO is recording all that. The fetal heart is, that is a proper record of the fetal heart. Plus, once the patient goes into labor or you are inducing her, so, the recordings of the fetal heart with contraction, post-contraction, every 15 minutes, there should be a chart which is, kind of showing those records. I think that's very important to safeguard yourself when actually the event happened.
Thank you.
Can I come in actually?
Yes.
Normally what happens in induction of labor, you have to have continuous CTG. It may not be available in other places where you can actually do every 15 minutes monitoring. But if you are having a CTG, it has to be regularly visited, signed, and shown what action you have taken if you have noticed something gone wrong or something which you're anticipating. Supposing if your variability is not correct and variability is not good and you want to see another 20 minutes or 40 minutes, the action plan should be there in the case sheet itself and on the CTG. So this is very important. The CTG has to be visited periodically, signed, and documented on what action you have taken. Another important thing is that when the patient goes, the discharge slip should show exactly what had happened and the future management plan. And as safeguards is also a basic medical legal knowledge should be there and indemnity should be there. So these are our safeguards. And we should also anticipate whether the patient will create problems. If the patient starts creating, or you anticipate about that, then necessary action has to be taken by informing the medical superintendent or something like that. And regarding documentation, I think documentation, if there are any notes previously, it should not be altered. It should not be tampered. You should not use any to erase it off. Just a little small line, you can just do it. But these documents have to be really written properly. So this is very important.
Very nicely covered by all of you. Thank you. I'll take you a step further. Now, when there is a stillbirth, please see it as a case for potential litigation. So here we are talking about all the IPD record, but tomorrow, if there is a notice saying to you or a case is put up, you will also need all her OPD records, all her visits to any other gynecologists, and all her investigation reports. Normally, when we keep it in the file or we look at correcting our notes or correcting our documents, we generally look at the IPD starting from the point when the patient was admitted. But here, when you see, a lot of times you will be caught unawares, but here it is a potential problem. So make it mandatory that you have a photocopy of all your OPD prescriptions. If they are not in the electronic mode and you don't have it with you throughout, then this is a chance that you should have all your OPD prescriptions photocopied, attached in the case sheet. All her investigations that you have asked, they should be attached in the case sheet, because how else will you then fight your case that you did as per the standard of care or you did as per what is the present norm. So you need to document it and you need to evidence it. So those investigations have to be, a photocopy of that should be there.
Actually, we are asking for all the antenatal records of her if the patient is registered with us. At the time of admission, when all the patients are coming, we are taking the antenatal records, the ultrasound investigations.
In these situations, if it is being done for all, yes, that's an ideal situation. All investigations, all OPD records, if she's been to any other gynecologist for any other opinion, that also has to be taken care. A very important thing whenever we talk about an intrapartum stillbirth also is the growth velocity of the fetus and the growth charts that are extremely important. You may not have a low birth weight, but you may have a fetus that had a 50% potential to grow. There was a sudden drop in centiles to 5 or 10%. Now, this is the fetus that is more likely to undergo hypoxia. So if you are not in the habit of plotting a growth chart, these charts are very nicely available on perinatology.com. There are some radiologists who give you the report in a chart form, but if not, please make it a good practice to have these charts downloaded in your clinics, attached to each of your files, so that you can plot and you will have a basic idea that this fetus may not be able to take up the stress of labor and is more likely to go through an intrapartum hypoxia. Now, the other thing is, when we talk about how you have managed the case and how you will defend yourself for an antepartum and intrapartum, it is you need to ensure that you have followed the basic standard of care. Your case will be sent to a peer review. The judges do not understand the medical lingo, so it is going to be sent for an expert opinion. So what is the standard practice in the profession that we need to follow? So intrapartum, you need to document and it is good to have a partogram, and it is good to document your fetal heart. Whether you have a CTG or you don't have a CTG, that is secondary. Not all places will have a CTG. So a clinical auscultation is also good, provided you have followed the norms every 30 minutes in first stage, every 15 minutes in second stage, and then 5 minutes. So that needs to be followed. That what is the standard practice we should be ensuring. CTG, it's a very important practical tip. They generally fade over a period of time. So if when you are putting up the CTGs in the file, please put in a Xerox copy or a photostat copy of that, because like ECGs, your CTGs will fade and you will not be able to then show that half an hour back it was working and all the parameters were absolutely fine. And then whatever discussions you have had regarding the management of the case before stillbirth and after stillbirth, all those discussions need to be documented very clearly.
One point that these NSTs are actually on thermal print, which fade off with time. So whenever there has been a bad incident, all those NSTs should be photocopied and then put in the file.
That's exactly what I said, ma'am.
Yeah,
So
because a medical case may take years to settle. And
Absolutely.
by that time, our thermal print is definitely gone.
Absolutely, totally agree on that.
And another thing is that we should get into the habit of taking the file of the patient for every case, because if the IUD has occurred, then they will never give you the papers.
Yes.
So if we are but it's very difficult to enforce it in the hospitals. The staff doesn't listen, and it's very difficult to tell them sab kuch photostat karo. They will do one paper photostat, 2 papers photostat, because hospitals are not having very good photostat machines. And somehow these things are very difficult to handle. Although I do try my best to put the papers in the file, but sometimes it is very difficult. The staff is not cooperative.
But ultimately, ma'am, the onus falls on us.
I know, Dr. Nidhi, but practical aspect भी देखेंगे. तो मैं generally क्या करती हूँ that my first prescription, the last prescription and my investigation sheet, I put all those photostats so that I have how the patient came to us, what was the history, what were the minute details of her medical history, the last and all the investigation sheet. So if I'm able to manage these 4 or 5 sheets also, it helps me a lot.
Yes, absolutely.
And as I told you, Dr. Nidhi, digitalization of the CTG graph is very important. If we store it with in computers or somewhere, then it remains very safe.
Yeah.
Because as you said, the papers get faded. But if it is digitally stored,
Yes.
then it will remain with you.
And this
I would like to re-emphasize one point, that I think plotting of partograph with all the parameters, whether fetal heart, cervical dilatation in relation to time, descent, if that is plotted religiously, and if there is any abnormality noted in the progress of labor or failure of descent, or there is cervical dilatation which is not taking, then what action has been taken on that, that is also documented very nicely. It will go a long way in, protecting us regarding this litigation. So those records are also very important.
How long to preserve these records? This is a potential criminal case. There is no limit on this.
They are-
Please preserve the records lifelong for this situation.
For any emergency case, the records have to be kept forever, because you never know when the issue will arise. So for all the medical legal cases, you have to preserve the records.
Dr. Archana, we are coming over to a very important question for you. What are the potential causes of concern for the OBGY specialist in this particular case? We go back to this case, 27-year-old primary gravida, routine investigations normal, comes at 38 weeks, mild backache, pulse BP normal, dating pregnancy, mild contractions, early PV findings. She stays far away, you admit her, she doesn't progress for 18 to 20 hours. You then decide to do an induction of labor, and when there is no fetal heart in the first stage. So what are the possible problems for the gynecologist here?
So I think, Nidhi, there is no mention of an admission test, whether, initial CTG was done to see
All
whether...
investigations initially are normal. Admission test is normal.
Okay. So I think...
because if the admission test is not normal, we probably would not have gone ahead with induction process. So the fact that we started that means okay at admission.
Have we considered the patient wishes, whether she wants to be induced or not? So this is very important. Have we taken a consent that she wants to be induced? So first thing I think is that, because that consent has to be in place, that she definitely wants herself to be induced and she wants to go into that kind of process, because induction obviously will take longer. So we can't decide on her behalf that we want to induce her and we want to deliver her, however far she's
actually a very important medico-legal point. How will you justify yourself that why was this labor induced? We had come to you in latent phase. 18 hours, the latent phase can progress much beyond that. So why an induction was done? So if you are deciding for an induction, please always be certain that you need to have a valid indication why you are deciding on induction, and of course a consent properly signed.
Even though there may be a pressure from the relatives, isn't it? Your patient, this index case had come from far and so decided to.
So then you need to document it very clearly that you are taking up induction of labor, but this is for logistic reasons. You are allowed to go ahead for induction of labor, provided the patient and her family understands the pros and cons of it. You've sat down, you've discussed with them, you've given them time to decide about it, and you document it very clearly that for logistic reasons, we are admitting her. But induction for logistic reasons, that is questionable. Admission is okay. But induction will be very sure why you are doing.
Yeah. So I presume all the minimum standard of care which we understand should be followed for a normal labor. They have been done, like, the CTG monitoring and all that has been done, and it is properly documented. So consent and documentation, has to be there of every possible step where things went wrong.
The other
if that has been done, there is no reason for,
Yeah. The other problem will come when how the case will be dissected will be, what did you use for induction of labor? So was it a recommended drug that you used? What was the route of administration? What was the dosage of administration? A lot of times we tend to follow that. In my experience, I have seen it with this. It works well in a number of situations, yes, but when you get caught up, it really boils down to the fact that what the group of experts is going to look at and what the standard literature says. So it is a good practice to limit yourself to the standard drugs, the advocated route and the advocated dosage, and to avoid combinations. That would be.
So we do actually use Savigel, Propes and all these things, and Synto only for induction. We are not using Misoprost. So probably that thing did not come to my mind.
Yes. So it is not just for here. This is an example, but practically it is any prescription error or any prescription that is going to go.
Yes,
it has to be these three things are mandatory: the recommended drug, dosage, and the route of administration.
True.
Just have half an hour more, so we'll quickly go through.
Just a minute, please. Dr. Nidhi. Dr. Sadhna has to leave. And she would like to give her comments. Can we just take a minute and give her some
100%, 100%, ma'am. We are looking forward.
Dr. Sadhna, please go on. We'll look forward.
Pratibha, ma'am, supposing in this case, during the first stage of labor, we have another situation. The fetal heart rate was apparently quite normal. In the second stage of labor, there are repeated fetal heart rate decelerations. Okay, and there are repeated fetal heart rate decelerations. You decide for a forceps to be applied. Consent was taken for forceps delivery in the second stage. A very specific question: will this consent hold true in the court of law? Is it okay to take a consent for forceps in the second stage of labor?
No, I don't think it is valid. First of all, it should be very clearly only outlet forceps. For that, all the criteria for outlet forceps should be met with. Then only we should think of applying the forceps, because mid cavity and high forceps are absolutely obsolete. And
Yes.
even the literature says that go for a cesarean rather than doing mid cavity or high forceps. So it should be only outlet forceps. Outlet forceps with deceleration, we can take out the baby very safely. But yes, consent will not be valid because patient is not in a fit state to give consent, and that consent is not valid at all.
Yes. So this
But
becomes
I
a
think we
big
are all
problem.
taking it. We are all taking a consent for vacuum and outlet forceps. How much it will stand in court of law, I think Dr. Sharda ma'am will tell us better.
Okay, so for then how to go about this situation is very rightly said that this consent will not hold true in the court because you are taking when a woman is in a state of acute pain. So when you talk of consent, she should be in that sound frame of mind. Now this word sound frame of mind is questioned by the lawyers that she was not in the sound frame of mind. So this is not considered valid. So how to go about it, Ram will guide us. But a suggestion that I have is when you are admitting the patient to labor, at that point of time, you need to have a documentation as to what the birthing plan would be, what the process will be. At no point of time can we ensure that she will always have a simple vaginal delivery. At that very point, we need to sit down and document with her. She may require operative intervention, vaginal or abdominal, in such and such a situation. If it happens for an operative vaginal delivery, what is the situation? And then for a cesarean, what all things we would require. We document it right there. We have that discussion when the patient gets admitted. You can try out these discussions in the antenatal period as well, but extremely important when you are admitting, it should be written very clearly. Ma'am, we look forward to your guidance, Sharda ma'am.
Yes.
Yes.
फर्स्ट ऑफ ऑल मेरा प्रणाम डॉक्टर शारदा जैन को और डॉक्टर रीना और डॉक्टर राज ने कानून की पाठशाला में जिसे कहते हैं गुणी जनों के संग गुण आ जाता है, तो मैं भी गुणी जनों के संग रह के कुछ गुण को सीख रही हूँ। तो ये बहुत बड़े भाग्य की बात होती है कि हमेशा हमें गुणी और बुद्धिमान जनों का साथ मिले। और NIGF में हम लोग लगातार कानून की पाठशाला कर रहे हैं, जो डॉक्टर शारदा जैन का आइडिया था और डॉक्टर संगीता और हमने 11 सीरीज तय कर ली हैं। और अगस्त में कोलकाता एक्सीडेंट के कारण हम लोगों ने उसमें थोड़ा सा ब्रेक दिया था। तो पहले तो बहुत ज्यादा धन्यवाद। और इससे पहले मैं अपने स्टिल बर्थ पे कहूँ, मैं आप सबसे अपील करती हूँ कि जो लोग फेलोज और मेंबर्स हैं ICOJ के, वो लोग वोट करना भूलें ना। और लिंक में कुछ लोगों को इश्यू आ रहा है, वो मेरे को मैसेज या कॉल किसी भी समय करें। सो वी आर रेगुलरली मेलिंग टू ICOJ ऑफिस, तो मैनी ऑफ देम आर रिसीविंग लिंक। सो द क्वेश्चन ऑफ अबाउट डेटा और समथिंग। इसके अलावा स्टिल बर्थ, पहले तो निधि से बहुत पुराना एसोसिएशन है। शी हैज बीन ऑलवेज a very spiritual and very clear person. बहुत कॉम्प्लिकेटेड चीज को निधि जितनी खूबसूरती से पैनल बनाया है, और सारे पैनल्स जिस तरह से मतलब लाइक इट इज समथिंग फ्रॉम लाइफ, एंड वी ऑल नो दैट सिंकिंग फीलिंग in our obstetrician. I think nobody in the world can share that feeling when we suddenly find that we are not finding fetal heart, and suddenly ultrasound, and suddenly for a moment we are totally doomed and we have to gather ourselves for all the things. But two or thing I will say, that we should never be so much emotionally involved. And secondly, like we prepare the patient for anything in course of pregnancy, right from the first trimester to last term, we should also make family and women prepared for this thing, that this is a new life and actually we don't know what is happening. So anything, constant pain in abdomen, less fetal movement, any sort of leaking, any sort of symptom, she should report, because anything like simple UTI, simple high grade fever, simple less of fetal movement can result into fetal death. So that awareness, and in our antenatal card, what I say, आपको ये चीजें होती है तो आपको report करना है, so that we are also ready for this, and it doesn't come to us as a shock. As in science, we know that this thing happens. 2 or 3 things like how to break good news or bad news. It is very easy to teach, but actually what happens, our reactions depend upon the attendant's reaction. If they are too much aggressive, they are too much emotional, then we have to actually reorient our way of communication. This is very, very important. अगर कोई जना aggressive है और defensive है, जैसे sorry शब्द हम नहीं बोल सकते, मुझे कई बार लगता है it is not never sorry. It is a fact that this baby is not alive. So that we have to learn through life कि एक भाषा सब जगह नहीं चल सकती है. जब वो लोग एग्रेसिव हैं तो हमको बहुत assertive, scientific होना चाहिए और अपनी security का ध्यान रखना चाहिए. When the people are emotional, understanding and cooperative, we can be more like sympathetic and something. So, and the third thing is that the reaction to this news depend upon whatever it is, the ANC period, it is the labor period, it is what it is period, and we have to always modify any degree of oligohydramnios, any degree of growth retardation to be explained very well to the patient, and again the need for the close monitoring. Nidhi has wonderfully said about what postpartum and the genetic and everything, and we have to offer them. It is like a DOT or something, unexplained death. Postmortem is for our savior. Likewise, in stillbirth for medical legal issue, if we offer them all these issues, whether they agree or not, and we take consent कि भाई हमको पोस्टमार्टम कराने की सलाह दी गई थी, हमको ये करने की दी थी और हम नहीं कराना चाहते, I think that will also end. So these are few things. The thing, it is the points are unending, but Nidhi has so beautifully concised all the points, and I will leave after 5 or 6 minutes. Thank you, Lina, for the invite, and thank you. And once again, I seek blessings from elders and good wishes from our friends for my upcoming election. Thank you very much.
Nidhi, you asked me a very particular question. So in fact, I'm not going to touch anything which has been discussed already. Now, coming on to the second stage outlet forceps. I think, whatever the consent has to be taken, if you take in by and large, 99% people are not taking any specific consent in the second stage of labor. Let me be very frank with you. You've already decided, if patient has got an IUGR or patient has got any antenatal complication and you're getting her infused, you will always say that, we keep a check on the fetal heart rate. You also keep a check on the fetal heart rate. If the heart rate increases or it drops or it is become irregular, then, one has to take a method depending upon how much is the cervical dilatation at that time. In case if it is like this and you are not close to delivery, then we'll do a cesarean section. But if it is a second stage, we apply an outlet forceps for which we don't take a signatures. And I think that particular signature, even if you take, it is invalid.
Didi, when we can I come in here, please?
Yes.
Didi, when we take a consent for normal delivery from the patient, don't we mention it all in that, because this process is too long, so it can culminate in normal delivery? Yes, one. It can culminate in an instrumental delivery at any stage, and it can culminate, third thing, into a cesarean at any stage. Yes. So I think it is understood once the patient gives consent for normal delivery, all these possibilities can be there. So in the beginning of the process, when we take the patient for normal delivery, all these things should be written down in the chart, that she is explained all these things.
That's absolutely important.
Here I will just wish to tell you that it is high time that we make a dedicated counseling session at 28 or 30 weeks where we tell them and the relative that it is going to be counseling session next time. Please get your husband or whoever wants to be there. At that particular time, we tell which place we are going to have a delivery, how the center is equipped. Everything is going all right at that particular time. The consent will be taken. In case if anything untoward will happen, either you will have a cesarean section or you will have a delivery vaginally. It can be assisted with forceps or it may not be assisted with forceps. So
that kind of, if they have had a briefing of that particular kind, take a consent that, it has been explained to them. So it is not that, you have not talked with them. When once it is documented on the antenatal record, I think, it is time has come that, you start talking.
Nobody can say that you did not give us time to think about it. You did it in haste, because then they are at the liberty. If they agree to your birthing plan, they are more than welcome to come to us. If they wish to go in for a second opinion, that is their absolutely choice. But then you would have written it very clearly. So that's a very important thing, that an antenatal birthing plan has been discussed.
The consent when she is coming to labor home, and then that consent is signed as a practice in our hospital. We are getting it signed from the patient and from the husband or the attendant. Both are signing all the three things: normal vaginal delivery, appropriate vaginal delivery, and then they mention forceps vacuum and LSCS. So we are taking a blanket kind of consent at the time of admission to labor.
I just wanted to come in. Actually, what happens is you might have counseled in any possible way, but when the lady is in second stage of labor and she's pushing, even if she does not have, she has the capacity to understand. So telling her verbally that whether you want an instrumental delivery or not, if she does not agree to it, we should not go forward.
Agreed. Yes.
मैडम एक बात है, झरना फालतू की बात कर रही हो. कितने लोग कंसेंट लेते हैं डॉक्टर साहब? खेरी तो बहुत है. मैं भी आई एम आल्सो वर्क इन मेडिकल कॉलेज. डॉक्टर साहब कोई कंसेंट नहीं लेता. डॉक्टर साहब आज की तारीख में वही रियलिटी है.
नहीं मैम, अगर हम पूछेंगे उनका
मैम if they don't give a consent, you will have an IUFD, get into trouble.
नहीं मैम, आजकल मना कर देते कि हम इंस्ट्रूमेंटल डिलीवरी नहीं कराना चाहते हैं, so we cannot go forward and do instrumental delivery. Even in second stage they say नहीं, हम नहीं कराना चाहते instrumental delivery. आजकल तो elective sections ही मांगते हैं मैम. Most of them come and tell me हमें elective, then we also cannot deny them elective also.
But there is no alternative of saying them no. You have to counsel them there, because at second stage when the baby's head is there, how can she say no? Then it is your duty.
In these days, the intranatal stillbirth is a big headache, and you can take it from me. 100% litigations are going to come. 100% litigations are going to come. So I think you have to be well prepared for this. All documentation, everything Nidhi has highlighted. What all you have to have it. And this is the only time that you can have the records attached to the file. You can keep a copy with yourself. And I think people like Dr. Gitendra and all who can be your consultant, you can talk to them. What extra I need to do at this particular time once the stillbirth has happened. I think they can also guide you what has to be done.
Yeah. Dr. Jharna, one question for you. The baby is born limp. Here we were trying to apply forceps. We have applied forceps. The baby is born limp, does not show any signs of life. You have started resuscitation, still no signs of life at 10 minutes. Do you declare it now? Do you declare it as an IUFT, or do you declare it as a fresh stillborn?
See, in this particular case, first I would like to say resuscitation nowadays, they say it's up to 20 minutes before you actually say which. And it is up to the pediatrician who's resuscitating. He is the person to say whether this baby is actually showing no signs of life. And if it is within 12 hours and there are no signs of any maceration, it should be the stillbirth, fresh stillbirth. We say when it's within 12 hours, the death has occurred within 12 hours and they show no signs of maceration. And if it is more than 12 hours and there are any signs of maceration, then it will be an IUD. So, but the stillbirth has to be decided by the pediatrician.
Yeah. The important point is 20 minutes, the resuscitation has to be attempted. Previously, we were talking about 10 minutes, but now the guidelines have changed. So resuscitation should have been done for 20 minutes before they put it as DNR. A tricky situation. The same patient was a known epileptic since childhood, did not disclose to her husband, has told you in the first visit, but has requested you not to write and disclose to the husband or his family. She now has a seizure during further augmentation of labor. Apart from Dr. Jharna, if there is anybody else who would want to also give an opinion on that, how will you proceed? Should you disclose this to the patient's family?
I think there should be a balance between the confidentiality, as the patient asked, and the injury to the other party. In this case, it is the newborn, it is the fetus. So, if she really, though the epilepsy is not going to harm much if it is of less frequency, but in this case, it has occurred. So it is very important to tell the relatives about the condition of the patient, because sudden this epileptic fit can cause an IUFD.
Yeah.
So, but we have to save ourselves also. So, as per the NMC guidelines, you have to balance between the confidentiality and the damage which is occurring. So, if she, from the very beginning in the pregnancy, if she says don't disclose, then please take a consent from her that I've been explained about the consequences of epilepsy during pregnancy, and these can be the problems which can occur during this thing. Even then, I don't want to disclose it to my husband or the family members. But definitely, there she has to give a person's name whom we can disclose. So this is very important. कि आपने husband को नहीं बताया, आपने उनकी family को नहीं बताया. But then, yes, ma'am.
Your duty to ensure the patient's safety. So if she has a seizure at home, not necessarily in labor, there should be somebody who knows to identify a seizure and to help out in that situation. So the best would be to counsel her, to make her agree to it, that in whatever form she wants, she should have a person of contact at home for her care.
Yeah, can I come in actually? Over here, there are two issues. One is confidentiality, and when is the breach of confidentiality? So confidentiality, there is a role of the physician and the role of the patient. The physician should actually keep the confidentiality of the patient, whatever he should honor, and the patient also has got the right to whom to disclose or not to disclose. But the patient loses the right once she loses the capacity to understand her situation. And in emergency, in labor, she is not in the condition, sound state of mind to understand that whatever is going to happen to her is going to harm her for her own benefit. In emergency condition, if she throws a fit when she is not in a condition to understand, then you have to disclose. But prior to that, you can just counsel and tell her to whom she wants to disclose. In case of an emergency, to whom she wants to disclose. She may not want a husband, she might want a friend, she might want a mother. So then we can disclose to the appropriate person.
So it's already 8:50. Finally concluding, obstetricians need to be aware of the laws related to stillbirth. Stillbirth has to be medically certified by a fully registered doctor or ANM. That doctor or ANM must have been present at birth and should have examined the baby after birth. The legal definition in India, we still are controversial whether to take it as 24, 26 or 28 weeks. But this is beyond doubt that all stillbirths have to be notified and certified. The Registration of Births and Deaths Act 1969 says birth means whether it is a live born or a stillborn, and it is the duty of the midwife or whosoever is the doctor or the health attendant present at the time of the birth. The keeper or the owner of the place that has been set apart for the disposal of dead bodies, that person also needs to notify, or any other person that the state government identifies. Now, supposing at any point of time you think that there is a suspicion of a deliberate action to cause stillbirth, then the local police needs to be informed. The fetus, the body is respectfully covered and respectfully handed over to the relatives. What to do in a situation if the parents refuse to take the body? This is a hypothetical situation, but somebody somewhere might get caught, so I thought of bringing it about. So any of one of you might want to take it up. What to do if nobody wants to take the body?
Inform the police.
Absolutely. So like we have of an unclaimed...
You must inform the head of the institution also and the police.
So the hospital administration needs to be informed whenever a stillbirth has occurred, more so if this is the kind of situation. And you also need to inform the local police. Again, be absolutely certain that there are no signs of life. This is the other thing.
And secondly is, whenever you find that the emotions are going very high in patients' relatives, it is good to inform the police yourself. वही वाले कृष्ण कन्हैया जिसको जो पहले बुलाएगा वो तो उसी के साथ आएंगे. तो it's always good to you should take a initiative of informing the police instead of those people trying to get the police.
And this is the stillbirth form that is required to be filled by the government. This has the set format. So this part is to be added to the stillbirth register. So that means we need to maintain a stillbirth register in our labor rooms. And these are all the columns that need to be filled. Wherever possible, in detail, the cause of fetal death also as much as possible that we can fill it up. Thank you.